Now, this was one of the patients where I told you about attack of uveitis during COVID times. This young lady, 8 years post ICL, had bilateral uveitis following COVID vaccination, and went on to develop a very with almost with hypopions, and we were able to treat it, but patient went on to develop bilateral intumescent cataracts. And you can see a PI there because there was an iris Bombay formation with the uveitis, and we had to do a small laser iodotomy which became so big subsequently. But eventually we could control the pressures and everything, and the only thing was that expanding the ICL here, this also required a toric ICL. So you can see that I'm trying to get the ICL out. It was a little challenging because the pupil was now rigid and small, and I'm staining under the ICL because this is a white cataract now. And the moment I decide to decompress this lens, and you can see that the moment I touch it, it goes into an Argentinian flag sign. So I was trying to decompress, but I didn't even get a split second, and this went into, it was a very, very intumescent cataract. And then of course I had to manage the surgery. It came out well finally, and I could place the lens. Second eye also looked similar, and there we went ahead with a femto-assisted surgery. So here we managed to do it with a femtosecond laser. Now with the femtosecond laser, it poses a few challenges because the laser cannot detect the ICL's landmarks, and you have to adjust them. In fact, it detects the optic edge as the pupil size. So you have to set all the landmarks right before you fire it. But it becomes much easier because you will not have a Argentinian flag sign for 90% of the times, and you will also be able to get a rexis in place nicely under the ICL. So you can see here that we are firing the laser after setting the benchmarks right. Also I did an LRI for the astigmatism, and here now you can get the ICL explantation and nicely ensure that the ICL comes out. Should not be challenging. Of course it should be done under visco, and then do the cataract surgery in the routine way. So essentially what I wanted to share was that cataract surgery is requiring a few more skills than conventional surgery for cataract surgery, but it's not difficult to do, and once you get comfortable with it, biometry is not a problem at all. Getting the ICL out can be a little bit of a learning curve, and the incision management should be more important. Other than that, everything looks great. Thank you.
Nice presentation, Dr. Gaurav. One thing I had to ask, can't we cut the IOL inside rather than making a big incision?
So we can cut it inside,
yes.
Absolutely. And some people actually what they do is they explant the ICL and they go ahead and do the phaco under the ICL.
Okay.
They don't bring it out first. So
okay.
they make a small incision, they float up the ICL, they go ahead and put viscoat under it, and they complete the cataract surgery and then implant the lens, and then they kind of bring the ICL out. So that's another way to do it. But you're right, it can be cut. But the good thing is that the ICL, just when you pull it on a 3 mm incision, it just comes out, it folds on itself and comes out automatically. So, doing manipulations inside and cutting it inside may cause some endothelial damage. But yes, both things are entirely correct.
What's the idea of doing under the lens?
The idea is that they don't have to enlarge the incision, sir, to bring the ICL. So they are still working from a very small incision. So they just float up the ICL, complete the cataract surgery, and then bring the ICL out.
Nothing to do with saving the endothelium?
No, in fact, I don't think it's very endothelium friendly. I would think that, getting the ICL out is better than allowing it to, float up and touch the endothelium. I personally don't do it.
Also, it will interfere with the procedure, basically. ICL will be disturbing all the way because you have to chop.
But, some people like to do it like that, and they've shown videos. Maybe they just want to show that it can be done, So.
All right. Thank